Morning, everyone. I'm Christopher Liao. I'm the National Entity Sales Manager here at CaptureRx. I'm very glad that you guys could join us today. I know your schedules are full, so we really do appreciate you guys taking the time out of your day to join us to do a little bit of learning with us. Today's topic is going to be one that has the potential to unlock a lot more value from your 340B program. As you guys are familiar with, it's referral capture. And I'm especially excited to introduce you to our new white glove solution, ReferDoc Premium. Here's what we're going to cover today. It's going to be a quick refresher on ReferDoc self-service, insights on the revenue potential hidden in referrals, also an introduction into ReferDoc Premium, our expert-driven service designed to remove operational burden and maximize referral capture. And finally, we'll close out with some Q&A to tackle some of your specific questions. Savannah will be moderating the questions and answers, and she will be presenting those at the end of the webinar. But before we jump in, I'd like to introduce my fellow presenters. First of all, Savannah Rideout. Savannah is our implementation data analyst and files expert. She is also our ReferDoc product owner. And also joining us is Mike Summers, our referral capture operations specialist. And he will be answering some questions and presenting as well. But to kick us off, I'd like to hand things over to Savannah Rideout, who will be walking you through a refresher on ReferDoc and highlight a few key features that ReferDoc is currently providing for you. Savannah, the floor is yours.
Wonderful. Thank you, Chris. So ReferDoc, the standard self-service model, is for the covered entities that have a little bit more time, have 10 minutes every week, 30 minutes every month to go through their ReferDoc claims. And with that, so we automate the capture of referral prescriptions. And with that, it's really the matching. And so we're receiving your patient encounter files, we're receiving your e-prescription records, and we recognize the patient, and our Cumulus system doesn't recognize the provider. And so it is funneling all of those claims after it does a pre-filtering into the ReferDoc queue for you to review and deem its eligibility. It integrates seamlessly with your already existing Cumulus account. So it's really just something that is turned on our end, and flip of a switch and the claims start to accumulate as we receive the claims from your pharmacies. And it reduces the manual workload because with our pre-filtering, it's doing a pre-adjudication. So it's making sure that all of those claims that are going to be shown to you in ReferDoc would approve at the time it's put into that queue. And it does a weekly refresh to make sure that anything in that queue is still eligible for referrals. And it's taking everything into account, manufacturer blocks and any conditions or financial criteria that you have set up with your program already. And Chris, you can go ahead to the next slide. Perfect. So 4 key ReferDoc features that you should be using. So ReferDoc is built for you, and it is kind of built to make sure that you get the most out of it that you can. So it is completely customizable. You can search per pharmacy, per provider. You can really narrow down that search criteria to whatever it is that you're looking for at the point that you're looking through the claims. So you can see everything, or you can just see a limited amount depending on what you need at that time. And specifically with the specialty drug flagging. So specialty drugs, they'll come up a few times during this webinar, but they're a high value drug. And so those are the claims that you want to be able to mark as eligible and review sooner, because it does give you that higher net savings value. And with our Cumulus system in ReferDoc, you're able to filter those claims from highest to lowest net savings. It does that calculation for you so that you're able to see that estimated net savings and work on those claims that have a higher net savings value before you do other claims. So if you're a covered entity that wants to dive into ReferDoc for 20 minutes a week, you want to get those high value claims sooner rather than later. And with compliance notes, you're able to leave a note. So once you've gone through and you've reviewed your activity, you're able to leave a quick note of where you got that information, what you reviewed, to be able to refer back to later and go back into Cumulus. And should you need it, that note will be there for what made that claim eligible at that time. and monthly performance insights. So once you mark a claim as eligible, that claim becomes a claim like any of your other CaptureRx claims. So it funnels its way into all of our reporting. So your EOB reports, your self-audit reports, your dashboards, anything that you have set up, you can see cumulatively with all of your other claims. And you can also see your ReferDoc claims specifically by filtering those reports. But it does give you that really good information that you're already getting with your CaptureRx platform. Go ahead to the next slide, Chris. Perfect, thank you. And the real impact of missing referral claims. So this is a big one. Once we enable ReferDoc, you're going to be able to see all of the additional claims that are funneling into us that only have that patient match. So referral prescriptions represent 20 to 40% of your total 340B claim potential. And with that, the specialty medications from referrals are frequently uncaptured. So keep in mind, these are you're providing the primary care to these patients. And so when you have those specialists writing those specialty drugs, sometimes those don't necessarily make it in, and you're going to miss out on that revenue should you not have ReferDoc enabled and be able to see and review those claims. And pharmacy processes can create gaps in claim volume, resulting in lost revenue. So with specialty pharmacies in particular, you're providing us a NPI list, or we are sending them your NPI list to receive those claims. And for ReferDoc, it would be just your known referral providers. And with this, Chris will talk about it a little bit later, but with specialty pharmacies, there are some different ways that claims can be sent to us that gaps wouldn't be created with those NPI lists or known referral NPI lists. And finish off, missing just 30% of referrals can mean significant revenue loss, especially with high value specialty medications. And so this is a big one. I'm looking at a lot of names that I've had the pleasure of training and getting excited about ReferDoc and seeing that net savings accumulate and working through claims. And it really does add a lot of value and a lot of additional net savings if you're actively going through the claims or going through it at a time in which you can, for however long you can, getting those high value claims and adding that net savings as much as possible. It makes a huge difference and is a big percentage of total revenue. And with that, I'm going to go ahead and send it over to Mike Summers to talk more about the ReferDoc platform.
All right, thanks, Savannah. I really appreciate it. I want to start with about our policy and procedure. So as everybody on the call already knows, HRSA offers a ton of guidance, but not a lot of regulation. So it creates a lot of gray areas with the program in general, and that is not, the referral capture aspect of your program is not immune to that. So we have to define how we're going to exist in these gray areas. From a policy and procedure standpoint, if you don't have one, we're happy to help you to do that. That's part of our ReferDoc Premium offering that Chris is going to talk more about later. But some aspects that are specific to referral capture that you're going to want in your policy and procedure. And number one, time frame. So what is your patient eligibility time frame for your program just in general? But also, what about referral? Outbound referrals or notes coming back in from specialists? Do you have time frames in your PMPs specific to those? Some organizations, most organizations actually, they don't require subsequent referrals out. So if you refer out once, then that is a redundant sort of thing to have to repeat it at set intervals. So it is a one and done type of referral out. But if you are requesting notes back, do you have a time frame that you are holding yourself to from a compliance standpoint for how often you have to have those notes back? We'll talk more about that later, but that is something that you would want to spell out in your PMPs. Speaking of referrals, one thing that you should consider is how are you going to handle formal versus informal referrals? What do I mean by that? So a formal referral or a structured referral is the process that you take in your health system in your EHR, a specific location that's reproducible, that happens throughout your entire system, to where a structured referral goes out versus an informal process, which would be perhaps if the doctor doesn't make a quote unquote structured referral or formal referral, but maybe they put it in the body of a note. A patient sees cardiology, or patient sees Dr. So and so. That is considered an informal referral, and I've gone through HRSA audits and have had zero issues including those informal referrals as an eligible outbound type of metric. Now let's talk about the reverse side of that, coming back in, getting notes back in. Do you require it or do you prefer it? That is a small nuance, perhaps a splitting of hairs, but it matters from a P&P standpoint, right? Because if your P&P say that you require it, then you are now held to that standard. So simply changing the word from required to preferred gives you the latitude, so to speak, to, hey, I want to get this note back in because I know it is good for patient care. I know it is good for creating some continuity in the patient's care between what we're providing as a health system versus what they're getting from their specialist. But I don't want that necessarily to stop me from being able to pull that claim in my 340B program if it doesn't exist. So that's something to consider in your P&Ps. If you do have language that requires that note back, perhaps you can adjust that to give you greater degree of latitude there to pull in more claims. Also, let's talk about being creative. Let's face it, the world that we live in, 340B of 2025 is not 340B of yesteryear, right? Things are different now. We have to be creative in order to keep viable programs. I think we all understand that, especially now with all the rapid changes that are happening even this year. I want to talk about internal referrals. What is an internal referral? Maybe you're a health system that has 3 or 4, 10, 30, whatever child sites that are on a reimbursable section of your cost report. They're registered with HRSA. You're pulling those claims in the way you would normally. But maybe you also have some sites, some clinics that are not on a reimbursable section of your cost report. Therefore, they're not eligible to be registered as a child site. Maybe those clinics house some specialists in your health system. Well, if the patient has an eligible encounter at an eligible location, the parent or child site of your organization, and they're also seeing a specialist that's in your system, that is a really easy process in order to bring those in. Have an outbound referral from an eligible location, even if it's to your own provider. That enables you to pull those claims in, even from a site of your health system that is not quote unquote eligible for 340B on its own. I know that's a little bit of a muddying of the waters because it's your provider, but the location is specific. The location matters, right? A person comes in for an audit of the Bazell group or your annual independence, whatever the case may be, then they're going to want to know, where was this patient seen? And they're going to look at your crosswalk to make sure that actual location is in a reimbursable section of your cost report. Well, in this situation, it wouldn't be. So you can't treat it like a general capture. You have to treat it like a referral capture, which means you have to check all the referral capture boxes in order to do that compliantly. All right, Chris, if you want to, let's go ahead and go to the next slide. All right, let's talk about compliance. All right, we want to pull in as much 340B revenue as possible so we could stretch our resources and offer more comprehensive services, but we have to do it compliantly, right? So what are some compliance checkpoints specific to referral capture that you may want to keep in mind? Number one, you need to be reviewing your P&Ps. There are a lot of CEs that I've spoken with that they don't have P&Ps, or if they do have P&Ps, they haven't reviewed them since 2015, 2016. That is a compliance issue. If you go through a HRSA audit, you're likely going to have a problem in that area. So make sure that you are reviewing those with your 340B steering committee or whatever your normal process is in your health system to manage that, at least annually, or if you make any changes, any revisions as well, that's a great time as well to go ahead and just do an overall review of your P&Ps. Next, let's talk about documentation. So in the referral capture world, there's a few token phrases or coined words that mean something. And one of those is that you are responsible for the patient's care. So an auditor, when they're sitting down with you and they're auditing perhaps a referral capture claim, there are going to be some checkpoints that they're going to want to look for. They're going to ask you, do you require a referral out? Do you require a note back in, et cetera? But what they're really trying to get to is not so much these black and white boxes of did this get checked, did that get checked, and more of is there supporting documentation in the EHR that this patient's care is the responsibility of this health system? And if that's the case, then you have a strong established documentation there that you'll do fine with in an audit. So primary care visits where you're managing people's chronic diseases, that's definitely a good established documentation type of pathway. If they're just there for vaccine, or they came in because they had a UTI, they never saw you again, probably not really responsible for their diabetes care, right? In those scenarios, so use some common sense and also just some wisdom there, clinically speaking, and what is appropriate. And that referral out, it is very helpful to have some continuity there, to have those structured referrals out placed in the same place inside of your EHR. It makes auditing much more simple. But we can also use informal referrals for that as well. That is a very, very common practice in modern referral capture. Right. Also, audits. Are you doing your monthly audits? Are you doing your annual independence audits? In those audits, is there a mixture of referral claims in there as well? That is a really good practice. HRSA expects that to do as well. We've talked about the note back in. I think there may be a question perhaps that we can get to later about that. But if you are going to require a note back, HRSA wants to know how often you want that note. Do you want it every 12 months, every 2 years, every whatever the case may be? Just define that if you're going to require it. If you're not going to require it, simply using the lingo as preferred would be acceptable. Chris, if you would move on to the next slide for me. All right, tips for success. Number one, use dedicated human resources. Key word here being dedicated. 340B is a very unique space. It's very knowledge dependent. Referral capture even more so. It's just a smaller compartment within inside of 340B. So using dedicated resources allows you to develop staff either internally or external from your organization, such as our white glove solution, where you have true experts that are working on something that's all they do every day, right? So they're really good at this particular facet of the program being referral capture. Number two, don't underestimate or unappreciate the value of all referrals. What do I mean by that? There are certain specialties that we may not just immediately knee-jerk reaction associate with a 340B benefit, one of which is eye doctors. I'm not sure. I'd be interested to know how your health system does in documenting those type of referrals. But if you have a diabetic patient, your providers are going to expect them, once they reach a certain age, of course, to have an annual eye exam. And those glaucoma drops are really expensive and can be of value to your program. So don't underestimate those. The last tip for success I want us to talk about, or next to the last rather, is how to maximize the benefit of the work that your staff is already doing, right? Because if we're going to make new processes, then we're making new work. Perhaps we could take the work we're already doing and glean some 340B benefit from that without creating really any new extra labor, or not materially so anyways. What do I mean by that? Number one, chronic care management. 2025, most healthcare providers are doing chronic care management in some capacity. And chronic care management and 340B, they run hand in hand. They are very complementary and symbiotic of one another. Most of the drugs that you're pulling in through your program, they're going to be for chronic disease states. So these chronic care management visits, they're getting information from the patients about the specialists that they're seeing, the medications that they're writing. They may even be requesting those notes back from the specialist to close that loop of care. Leverage that, utilize that, review those as you are looking, is this eligible or not eligible for a referral capture potential. Oftentimes you will find that the work has already been done there. It's just a matter of dotting the I's and crossing the T's before we pull that claim in. Next, let's talk about MedRecs. When your nursing staff or your clinical staff in your health system are doing MedRecs with your patients, it's a really, really good time to get a bigger picture of the patient's total healthcare story. Oh, Mr. Smith, I see you're taking Xarelto now from, you weren't taking that when you were here 3 months ago. I know we didn't write that for you. Well, what provider is writing that for you? What disease state is being treated by that? Did you have a blood clot disorder or whatever the case may be? That's a really good opportunity to identify potential outbound referrals that have not occurred yet in your health system that you can then make a referral for the patient to continue seeing that specialist. Along those same lines, how do you handle patient self-referrals? This is a topic that's come up a lot from the various health systems over the years, and I think it's valuable that we talk about it briefly, right? So maybe you got a patient that's been seeing a cardiologist for 10 years, but they're new to your health system. They just established care with you. You are responsible for them now. They're falling underneath your umbrella. How do you handle that self-referral when the patient's already seeing them? It's quite simple. If they're seeing that cardiologist or whatever the specialist may be, and you're satisfied with that care and that particular facet of their healthcare story is being adequately cared for, and you want them to continue to see that specialist, don't you also want to have information from that specialist, right? So it would be a perfectly reasonable and very common practice to put in a referral for continuation of care with that specialist, and that gets you in the loop. So you'll be in the know of whatever's going on with that patient's cardiac condition that maybe you otherwise would not be in the know on if you weren't getting a full picture from that provider. Pretty easy. Most of the time, you can get those notes back just over a phone call, or you may have to get like a signed medical release form to fax over to the specialist office just to say, hey, this is our patient now. We want to be in the loop on their care moving forward. Those are some tips for success that I think you should consider if you're not already considering them inside of your program. Chris, can we move to the next slide? All right, last. Simple, don't settle for low-hanging fruit. What do I mean by that? Well, I grew up in Mississippi. I live in Mississippi now. So I can't help but think about in the fall, since we're getting close to that time period, where I would go out with my adopted grandmother, picking apples, picking pears, picking figs, things like that. So you got the limbs that are on the lower part of the trees, and those the fruit on those branches are relatively easy to get through, right? You walk through, you pick them, but once all that fruit is picked, you got to climb a ladder, right? You got to move up into the tree. You got to go up into the higher branches and shake out the fruit, because the fruit up there makes just as good pies as the fruit on the lower hand branches. What do I mean by that? Manufacturers have been picking the low-hanging fruit since 2020, and it's increasingly becoming more and more so with MFP process that's coming out, with the rebate model pilot that's coming out. There's going to be less low-hanging fruit for us to pick. So in order to continue having the type of success in our program that we're used to, somebody's got to climb the tree, right? Somebody has to go up for those higher, those high value claims that are more difficult to get to. And it's still there. It's still value. It just requires more work to get to those. I think that's the heart really behind our ReferDoc Premium white glove solution, what we can be leveraged by your health system to do that type of work for you. Chris, I want to hand it off to you. I know you want to speak some to the white glove solution.
Thank you so much, Mike. I really do appreciate it. And I do love the analogy of climbing the tree higher to get to the harder to reach fruit, because that is exactly what the ReferDoc Premium product is designed to do. If I say RDP, that's just an acronym that I use for ReferDoc Premium, and I might slip that in there, but I don't want anybody to be confused if I start utilizing that. So let's talk about ReferDoc Premium. It is our expert-driven, zero-burden solution. So what that means is we're going to utilize the already existing ReferDoc technology that you may already use, but now we've enhanced it with our hands-on expert support with our ReferDoc Premium team. And what that means is that your operational burden or your learning curve is absolutely zero, because our team is going to be taking care of everything for you. So we'll handle the heavy lifting from claim identification, referral note collection, policy and procedure review, auditing. So there's no chasing down specialists, adding a new workload to your staff. Everything is done with HIPAA, HRSA, and OPACE compliance in mind, and backed by sub-BA protections. And best of all, I mean, your payment processes and your PSA relationships are going to stay exactly the same. The only change is going to be to your TPA, where obviously you're bringing on a new product, which has a different pricing structure. But yeah, no operational burden for your team. So you guys can just focus on patient care, which is ultimately at the end of the day, what you guys are best at. So how does it work? So ReferDoc Premium works a little bit differently, because first and foremost, we would want to integrate our processes with your EMR to ensure accurate and organized data collection and HRSA audit readiness. So we want to make sure that everything is organized inside of your EMR. So if you do get HRSA audited, notes aren't just all over the place. Similar to what Mike was saying earlier about the informal referrals, we have everything kind of in place to be readily referred to and referenced. So that way those audits go smoothly and quickly, and there's not a lot of, extra time added or delays. Automated import and claims review process to ensure the highest approval percentages. That is what the current ReferDoc technology is doing for you. But that is also, part of the ReferDoc Premium product. We do have secure file transfer protocol communication bridges set up for seamless and secure PHI transfers. And Savannah mentioned this a little bit earlier. Doing the regular prescriber list submissions are one way to be able to get the claims from specialty pharmacies specifically into our system. But if you don't have a list of those specialty providers and their NPI numbers readily available, there's going to be missing claims that are not getting into the system to be able to be pushed into the ReferDoc queue, whether you have self-service or premium. So there is a patient census process that has been adopted by most of the specialty pharmacies, not all, but this is a way for us to be able to share patient census information, which is minimal data, which is patient's first initial, last name, date of birth, and their zip code. We do understand that's PHI, but there are going to be protections in place across all parties to ensure that everything is securely encrypted from end to end. And this way, it actually casts a wider net and allows those claims that may have been missed previously to then enter the system and be worked by our ReferDoc Premium team. And we do have transparent results. So everything's going to be able to be tracked in our self-audit report, in our EOB report, and also in the Cumulus dashboard. And Savannah had mentioned that previously. So ReferDoc and ReferDoc Premium, we're not going to work any claims and not have you guys have 100% visibility into the claims that get worked. And if you don't know how to look up what referral claims have been worked now, your entity account manager can show you through that, or you can even email me personally, because I was an account manager for years prior to getting into the sales side of things, and I'd be happy to show you that as well too. So as far as implementation, because obviously, implementation is always something that people are kind of weary about when it comes to, 340B, but the implementation process is extremely fast with this process as long as communication is in place. The plugin is already something that we just turn on. So if you sign the addendum, we can turn on the ReferDoc product, whether it's the premium or self-service model, within 30 minutes if necessary. But the first step would be signing the ReferDoc Premium addendum. And then we would get EMR access. So we would need to be approved for EMR access. We would then review your policies and procedures with our ReferDoc Premium team. Obviously, we would give guidance and advice to open up your policies and procedures, as Mike mentioned before, whether having preferred notes or whether having to have notes like an obligation, things like that. And we would review that with your team. But it's important that we do this because we want to make sure that although we may give you guidance, we want to be following those policies and procedures to the letter. So then that way you guys have the peace of mind knowing that your referrals are being worked the way that you want them to be. And then step 3 is beginning the referral capture process and just following the reporting. With the ReferDoc Premium product, though, you will get bi-monthly reporting to show you how the performance has gone with your referral capture program. So then that way you do have a quick bird's eye view of how everything is operating as you implement this product into your program. I really want to thank everybody in the chat, everybody that attended today for joining us. I hope you're leaving with a little bit of a clearer picture of how referral capture works, and specifically ReferDoc Premium, but how much of a major impact it can have on your program. If you're ready to take the next step and do ReferDoc Premium, you can contact your client relationship manager, or you can give us a call at the 888 number, or you can give me an email. I'll put my email address in the follow-up, so that way you guys can reach out to me. But on behalf of Savannah, Mike, and the entire CaptureRx team, thank you so much again for your time today, and we look forward to helping you guys what's been missing your 340 program. All right, so have a great day. Have a great day, guys.
Thank you, everyone.
Bye, everyone.
Bye.